Okay. These are a couple of lectures that are dealing with, the first part is going to be on exercise and what happens to the cardiovascular system, cardiopulmonary system, excuse me, to be able to respond to the fact that there's an increase in carbon dioxide production, increased need for oxygen consumption, and we'll introduce some concepts, one of which is this concept of anaerobic threshold, that there is a point during exercise at which you can no longer function in an oxygenation state. You have to go to an anaerobic state. You can't function as an aerobic being. You have to go anaerobic, and we can measure that. And we'll talk about some of the exercise testing we can end up doing and how we can distinguish between cardiac and pulmonary limitations to exercise. And then we'll talk a little bit about the elderly. As we age, what happens to our cardiopulmonary system and what kind of deficits we end up seeing. I think on the final there might be one or two questions from this module, so it's not a real in-depth component, and I'll kind of point out what I want you to know for the final, and we'll go from there. Okay. A lot of my notes in here that you have must be from the old edition, because I think I have it as chapter 20. It's chapter 23. So he must have added a bunch of them when he changed editions. I just caught that this morning. So if you're going through it, it'll be chapter 23 and chapter 24. So let's talk about metabolic function. We know that whenever we burn fuel, burn substrates is the technical term for that. Primarily we're talking about carbohydrates, fats, and proteins. And the burning of those, the combustion of those, actually produces energy in the form of ATP, which we need for cellular metabolism, generation of proteins, blah, 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 blah. In order for stuff to function, you got to have some kind of a food being burned. The amount of energy produced is dependent upon the substrate being burned. Not only is it the amount of energy that's generated, but it's also the respiratory quotient, the relationship between how much oxygen is consumed and how much CO2 is produced. If you remember back, way before break, where no one was awake, we said this thing called the respiratory quotient was the relationship between the amount of carbon dioxide that is produced per minute compared to the amount of oxygen that is consumed. Okay. I would like you to know that the respiratory quotient when we burn carbohydrates is pretty much a one-to-one relationship. For every milliliter of oxygen that is being consumed, there's 1 milliliter of carbon dioxide that is produced. If you take a look at the other two, burning of fats and burning of proteins, it's considerably less. So from a dietary standpoint, patients with chronic lung disease who have a difficulty in removing CO2, wouldn't it make sense to put them on a high protein, high fat diet and not a high carb diet? And this is what we try to do. I don't know if you guys have seen in the grocery store commercials for something called Ensure. It's a liquid drink that has all kind of calories in it that you can use it as a mechanism to feed people who can't eat. We can give it through a nasogastric tube or through a gastrotomy tube. There actually is a special type called Pulmocal that basically is designed for patients with COPD, and it's a high protein, high fat, low carb diet. And it can make a tremendous difference having what COPD patients eat as far as how easy they are to breathe. It's something as simple as that makes a big difference. The other thing that I would like you to know is the number of kilocalories that are created for each different substrate. Fats have 9, proteins and carbs have 4.
You want to know the RQ for fat and protein too?
No, just know that it's less. Which is why we utilize a high-fat, high-protein diet. So far, so good? Got to burn energy in order to live, bottom line. If you don't have oxygen available, then we end up having an anaerobic process going on. We know that under normal conditions, you produce a significant amount of ATP when you burn something through oxidative phosphorylation. Oh my God, the Krebs cycle. When you go in the other direction and go with an anaerobic process, you create not only an extremely small comparable amount of energy in the form of ATP, you also produce lactic acid as a byproduct. And that lactic acid is a cause of a metabolic acidosis. Oh my God, we were just talking about that. Talking about blood gases. And that metabolic acidemia is the thing that will actually cause cellular dysfunction, mitochondrial dysfunction, and ultimately death. Just as an aside, fats can't be burned in an anaerobic condition. The only thing you can burn, actually fats and proteins, can't be burned. The only thing you can burn is glucose. So it becomes a very inefficient process, and we try to stay away from that under normal conditions. Just graphically, this is out of your text. On the top you can see if you're burning fats and carbs, you can see what you end up producing, and this is where they get the RQ component. 23 milliliters of oxygen yields 60 milliliters of CO2, which works out to be an RQ of about 0.7. On the bottom, we end up having the anaerobic process with the development of lactate or lactic acid, and not a very efficient process. So when we do this stupid thing, when we do this thing called exercise, what we need to, or what is going on physiologically, is we're attempting to match the amount of oxygen that is needed with the cardiovascular performance to make sure that for every milliliter of oxygen that is used, it's used effectively. What this means we have to have is, if you think about it for a half a second, you have to have effective ventilation, which some of our patients don't. You have to have the matching between pulmonary blood flow and ventilation. When Jeannie talks about VQ relationships on Monday, you'll end up seeing that that can be a real big problem in the face of both pulmonary and cardiac diseases. You have to have adequate hemoglobin. You have to have an adequate pump function, which means preload, afterload, and contractility have to be maximized. And if you'll notice, these two together is O2 delivery. This is alveolar minute ventilation. This is looking at the VQ relationships. So all the stuff we kind of talked about up to this point in time. We have to have systemic blood flow that not only is a cardiac pump function optimal, but also systemic blood flow has to be optimal. And then ultimately what we'll find next Wednesday, we'll talk about ventilatory control mechanisms, that the brain has to respond appropriately to an increase in carbon dioxide production to increase alveolar minute ventilation to match it. So it's a real complex system you got going on there, but it's basically all the pieces that we've gone through up to this point in time. It's graphically looking at the right-hand side being the pulmonary component, the left-hand side being the systemic component. We're taking in oxygen, exchanging it in the alveolar capillary membrane, transporting it to the tissues, exchanging it there, bringing it back, and the whole process hopefully works well. But any limitation at any point along that way can lead to the problem of inadequate CO2 clearance, inadequate oxygen delivery, and anaerobic metabolism. So when we exercise, we need a ready source of fuel, because you can't, eat and run at the same time. It just doesn't work that way. So what we do is we start converting the glycogen that has been stored. If you remember, the liver converts glucose to glycogen to store it. in the process. Now we convert it back into glucose, and that glucose is basically converted to pyruvate, and eventually the release of ATP for energy and the production of CO2 and water. How well we use the oxygen is really dependent upon the fitness of the individual. All of us have a point at where we go anaerobic, where the level of exercise, the level of cardiovascular response is maximized, and any further exercise you do is going to be done in an anaerobic fashion. This is why we end up having, when you exercise for a prolonged period of time, you start feeling the burn in the muscles. That's nothing more than the development of lactic acid in the tissues themselves because you've gone anaerobic. We call that point where you convert from an aerobic metabolic function to an anaerobic, the anaerobic threshold. Normally it occurs at about 50 to 65% of the oxygen, the maximum oxygen consumption that the individual can do. When you go anaerobic, you create that lactic acid. That lactic acid now is buffered, oh my God, there's that word, by bicarbonate ions, and you end up creating CO2, going the reverse of that hydrolysis equation. When we increase the CO2, we increase ventilation. We'll find that CO2 is the little trigger that is there to tell the brain to fire an impulse to the diaphragm more frequently. So I have a point where I can't use oxygen. I'm now using I'm now using an anaerobic pathway that's still going to produce CO2 without necessarily increasing the oxygen consumption further. So we can actually measure these transitions going on by looking at what we're going to call an indirect calorimeter. An indirect calorimeter is basically measuring the energy that is being produced when we're exercising. What we need is an oxygen analyzer, basically something that's going to quantify both the inspired and the expired amount of oxygen. If I know how much oxygen I'm taking in, I know how much oxygen I'm exhaling, the difference between them must be what I'm consuming. Same is true with carbon dioxide. I measure what I'm inspiring carbon dioxide, hopefully it's zero, because if not, you got a problem. We shouldn't be breathing in carbon dioxide. But if I know how much I'm exhaling, I can tell how much CO2 production I'm making. So I'm knowing what the VO2 is here, I'm knowing what the VCO2 is here. And I'm measuring my minute ventilation through a spirometer, just like we did here way back when. And then the final component is that I got to have something that gives a graded energy level. And if you've ever been on a treadmill, you know what that's like. You can start it off at a level incline at a very slow speed, and then you can manipulate either the increase in grade that you're doing if you're running up a hill, or the speed the treadmill goes at, or both. And that's what we do when we measure this, is we gradually increase the work that is required, and as you increase the work, you should see a concomitant increase in oxygen consumption, CO2 production, heart rate, etc., etc. Okay, so far so good. This is graphically what it looks at for those who care. Rip open a piece of equipment and look on the inside. Schematics are always fun. But basically, I'm monitoring somebody's inspired and expired gases and their minute ventilation and seeing their response to work. Here's what the system would look like. We have this young lady with this ugly looking mask on, but it's sampling the amount of oxygen and CO2 that they're breathing in and out. And she's on a bike ergometer to be able to change, instead of a treadmill, just basically changing the ease of pedaling that is there, and change the amount of work. And all that data then is captured on a computer, and it does all the calculations for us, which is a good thing. Now what you should see is oxygen consumption rising in a linear fashion. So as I increase work, the amount of oxygen I consume goes up in a straight line. That makes logical sense. If I'm increasing the workload, my tissues need more, they're going to consume more. The cardiac output also increases, and we see it both through an increase in heart rate and an increase in stroke volume, although at some point the stroke volume becomes limited. So with exercise, at some point, it's not so much determined by the stroke volume increasing to increase oxygen delivery. It's going to be the heart rate that's going to be the thing that's going to be increasing. We maximize the volume that we can pump out with each beat. Systemic blood pressure goes up. Systolic, blood pressure goes up. Diastolic does not. That's a normal response. And there is a predicted maximum heart rate that is age-related, and really doesn't matter how fit I am, the maximum heart rate still is that maximum heart rate. We'll talk about that. To be able to calculate that, you may want to know that, 220 minus the age. So if I'm, let's see, what would I be? 220 minus, I'm 57, so is that 163 would be my maximum heart rate. Being the well-fit person that I am, not, I'm going to reach that 163 or approximate it much quicker than somebody who is a trained athlete at the same age. They're going to be able to go for a longer period of time before they end up encountering this. So that's basically the essence of what we utilize. And if you've ever, has anybody ever had a stress test done, cardiac stress? You know what that's like, where they calculate your maximum heart rate. So linearly, the heart rate should go up with exercise. As I said, systolic blood pressure goes up, diastolic does not, but the mean still goes up. And oxygen doesn't end up changing under normal conditions. Ventilatory-wise, so we said heart rate goes up more so than stroke volume does. We maximize stroke volume, and then we just keep going up on the rate. With ventilation, there is a response in both the respiratory rate and the tidal volume that you end up encountering. Similarly to the heart, we maximize tidal volume, and then any further increase in minute ventilation's got to be accomplished by increasing the respiratory rate. So we end up seeing is really a pretty profound increase in tidal volume, up to 60 to 70% of vital capacity. So if I think, 4,800, 60%, well, that's a lot of, that's tidal volumes 2.5, 3 liters in size. So you got a huge tidal volume increase. Because the anatomic dead space doesn't change, the dead space to tidal volume ratio, the VDVT, actually goes down, which is, we're just basically maximizing or optimizing the volume of gas that are moving in and out of the lungs. Okay. Once we get to that point, once tidal volume reaches as big as you can go, just like the heart, you know, we can't increase stroke volume, we increase respiratory rate as a mechanism by which we increase alveolar minute ventilation.
So would tidal volume and stroke volume kind of plateau?
They plateau, absolutely. Yep. Now this concept is this anaerobic threshold. If you remember, we said that when you reach this anaerobic point, oxygen is no longer utilized for energy, rather we go anaerobic. In the process, CO2 is produced from that lactic acid being buffered by bicarbonate ions. I'll have to speak this one day. So as they, what you end up seeing is basically at some point, the linear response of the amount of oxygen that is being consumed and CO2 that's being produced, all of a sudden there's more CO2 being produced than there is O2 being consumed. One is linear, one starts having a little bit of a hook on it. a little bit of a rise that is nonlinear in the process, and that's due to that lactic acid being buffered. It's kind of hard to see on here, but here's my oxygen consumption as I'm increasing the work applied. It's linear. It's a straight line. Can you see that this one rises, but now at this point no longer becomes linear? If it was linear, it'd be continuing on that. I'm now hitting the brake. This point where it transitions is the anaerobic threshold. I will not give you a graph and ask you what the anaerobic threshold is, but there is a point during all exercise where that is reached. A more fit individual will have that happen in a much longer and a much higher work level than someone who is unfit. Part of what we do with patients with chronic lung disease is we can put them through training programs to be able to maximize their cardiovascular function and their pulmonary function to be able to improve their exercise ability. And that's been shown to actually reduce somebody's let me change the wording on that. It's been able to increase their longevity. Patients with chronic lung disease have better outcomes, less hospital administrations, less exacerbations of their disease when they go through a pulmonary rehab program than when we don't. Makes all the sense in the world to me, doesn't it? Anyone who has an MI, do we put them through a cardiac rehab program? Absolutely. Does it increase their lifespan? Absolutely. Is it reimbursed? Absolutely. Pulmonary rehab? Not so much, which is a pretty sad thing when you think about the number 4 cause of death. We have a way to prolong life, but we don't pay for it in the same fashion. Something's wrong with that picture. So again, unfit's going to reach that target heart, that max heart rate quicker than a physically fit person as we increase the work rate. Last thing I want to mention on this, and again, I would never give you an example of this and expect you to diagnose it, but when we talk about somebody who fails a treadmill test, somebody who, I shouldn't really use the word term, but basically becomes unable to continue even though they haven't reached their maximum heart rate yet, it can either be a cardiac problem where basically their heart muscle cannot generate the cardiac output that's necessary to supply the oxygen, and we see that by a nonlinear rise in heart rate. Instead of the heart rate rising in a linear fashion, there's a little bit of a curvature to it as we get towards the limit that the person can manifest. And this is in your text. It's very ugly looking, but it's basically talking about different conditions that can exist as to why somebody becomes dyspneic during exercise. This is a cardiac limitation that basically can't generate the stroke volume. Why? Reduced contractility, reduced preload, increased afterload. With a pulmonary limitation, on the other hand, the primary problem is the inability to generate a tidal volume that's large enough. Okay, so they have the inability to blow off more CO2 as the CO2 levels rise. So we end up seeing them having worsening problems. And what they end up having is they don't reach their maximum level that they potentially could. As you can see the normal lungs in red, the amount of an obstructive disease is going to end up being stopping well before that because functionally they can't generate that much volume in and out. And with restrictive diseases, the exact same process goes on. They already have a limitation in their tidal volume generation to begin with. It only worsens, and if that restrictive defect has a diffusion defect as a component of it, somebody with, say, pulmonary interstitial fibrosis, that individual is going to have a double whammy that they basically can't take the tidal volume in to generate the CO2 removal, but they also can't, let's see, when we exercise, We increase the blood flow past the alveolus. We decrease the transit time. And that's what's going to cause a hypoxemia developing in those patients. You can take a look at the case studies. This is an example of somebody who has a huge increase in CO2 production and O2 consumption, but really this is a fourfold increase in ventilation, and their RQ never goes above 1, which is what you would expect to end up seeing. So what we try to do is we try to go ahead and increase their function in a pulmonary rehab program, and they basically should have a targeted heart rate. I won't ask you how to calculate this, but there is a mechanism by which we calculated a maximum heart rate. I know what my resting heart rate is. I take 45 to 85% of the difference of those two and add it to my base heart rate. So here's an example of heart rate of 60. Maximum observed during exercise is 130. I look at the reserve, the difference between the two of them is 70, and I go ahead and I multiply that by 0.45 and 0.85, blah, blah, blah. You get a targeted heart rate. So when I'm exercising, that's the heart rate I should be exercising at, is basically the bottom line, is what you're trying to accomplish here. All right. Chapter 24, I think it's listed as 21 in your notes, is on aging. This will be very brief because it's a very depressing subject. Unfortunately, with age, our lung function decreases. If somebody has a pulmonary disease, say COPD, chronic bronchitis, that also is going to cause cardiopulmonary function to decline. The question is, how do I differentiate between the two? Is the fact that the person is becoming more dyspneic because their disease is worsening, or is it just the normal degradation in our lung function? A couple of things that ends up happening as we age. Our chest wall becomes less compliant. Just like arthritis affects a lot of other joints and connections within the body, same thing happens here. Our thoracic joints, where the ribs interact with the vertebrae and with the sternum, they start to calcify, to become less fluid, if you will. Our spine changes shape. The development of scoliosis is quite prominent in the age. You also have a diaphragm that becomes a little bit less effective. Instead of being this nice dome-shaped muscle that contracts, it starts losing its functionality. On the other hand, we end up having pulmonary compliance increasing, so thoracic wall compliance goes down. Pulmonary compliance, actually, the lung becomes a little more floppy. We start losing elastic fibers, and we end up having air trapping going on. And we basically end up having a decline of about 30 milliliters of FEV1 for every year that we continue on past the age of 25. And 30 milliliters, just to put it into a context, is about the size of a shot glass. So that's how much air we lose in our ability each year that we live. And then lastly, we end up having, because there's lung tissue that's missing, we end up having a decrease in diffusion based upon Fick's law. Alveolar volume goes down, you lose diffusion. Isn't that a pleasant thought? To make matters worse, our immunological response becomes less effective, so we end up having an increase in community-acquired pneumonias and the flu as we age, which is why we recommend patients as they age get not only the seasonal influenza vaccine, but we recommend them also getting the not the flu shot, thank you, the one for pneumococcal pneumonia, Pneumovax, I think it's called. Cardiovascular, What I want you to just remember is that the heart becomes, like the lungs become deteriorated. The heart does too. You start losing the ability of the left ventricle to adequately function. It gets a little stiff. Um, you end up having calcification of the valves. So the valves don't close as function. So you have a lot of backflow when systole occurs. You end up having murmurs developing. So preload is less because there's less coming in, less being ejected out. Bottom line is that you end up with patients that have cardiac output that decreases as age goes on. Heart rate also decreases. So not only does the stroke volume go down, but the heart rate also goes down just because the sinus node becomes less, it just fires at a slower rate. So a lot of times in the ages you'll see them with significant bradycardias present. And that's it. So that was a very depressing ending. Absolutely you can. Absolutely.